Hello, good morning, everyone. Hope everybody can hear me. My name is Emery Marjenoff. I am here. Let me go ahead and get myself set up so that you can see my screen. Alrighty, I should be sharing with you now. And let me go ahead and view my PowerPoint for you all. Okay. So thank you, Terry, so much. Like she said, I'll be discussing some sensory integration and sensory processing disorders with you. I know that we're all so excited to be here with you this morning, not only to share some information, but because as a therapist, I know that oftentimes terms are thrown around. We talk to you about different things all the time, what to expect, and especially with sensory, it's a very broad term and it's used so frequently and so often that it can kind of get convoluted and disorienting. So I will be kind of going through every single small tidbit about sensory today. By the end of this presentation, I hope that we all understand what sensory integration is, what sensory processing disorders are, why sensory needs are important, and how they can affect our daily functioning, how we can assess for sensory needs, and also how and when to use sensory input. So quickly, a little bit about me. I know that we say this on the website as well, but for any of those who have not checked out the website yet, which you should, I'm born and raised in Fort Lauderdale, Florida. Fun fact is that my dad is also an occupational therapist, so it kind of runs in my blood. I got my bachelor's degree from Florida State University in psychology. And after I realized that I didn't want to be a psychologist anymore, I went abroad for a year and I taught English in Spain, where I worked with adults and children. And that's kind of where I figured out, okay, I really like working with people and I really want to continue helping them. So my dad had whispered in my ear for a long time, I think you'd be great as an occupational therapist. And lo and behold, we rarely want to listen to our parents. But when I came back, I started doing more research and realized I did, in fact, love occupational therapy. So I went to Nova Southeastern University and received my master's in OT from there. And then after you finish your schooling, you do 2 3-month rotations, and mine were in acute care, and another one was in a pediatric outpatient child development center in Miami. And I really learned to love children. I learned to love the adult population, and I also am obsessed with sensory integration and sensory input and all things sensory. So this is a really awesome topic for me to talk to you about. And now I've worked in Storck Center and our high ability clinic for a little over a year. I work with the pediatric and adult outpatients. I work with our school-based therapy kiddos, our Department of Education children, and I also work in the intermediate care facilities. So I work with the adults that are residents on campus as well. And I love everyone equally. So what is occupational therapist's role in everything and also sensory? Our role is to help people across the lifespan participate in the things they want and need to do through the therapeutic use of everyday occupations. So a lot of the time when people think of occupation, we think, it's somebody's job, or what do? You help people find jobs. So no, occupations are actually every single small activity that you do in your day. Think about when you wake up and you get out of bed and you put on your slippers, or you go and wash your hands in the sink or brush your teeth. All of those small activities that make up your day are a form of an occupation. We kind of help you if you are having difficulty figuring out any of those occupations and how to do them. We help you learn or relearn how to do them functionally for yourselves. Our aim is to support health and well-being and participation through engagement in these occupations. And we also often help identify and address sensory integration and processing disorders or sensory sensitivities in clients ranging throughout the lifespan. Alrighty, here we go. I'm gonna put this down at the bottom of my screen. There, that's better for everybody. So what is sensory integration? Sensory integration involves perceiving, modulating, organizing, and interpreting sensations in order to optimize occupational performance. Okay, so that was a lot of big words. Basically, what sensory integration is all day long, we are perceiving sensations around us in our environment. And our brain, in turn, has to receive this information, process it, and all the little wires and connections in our brains have to be perfectly functioning in order for us to understand them correctly, right? So when there is an issue and something isn't connected correctly in our brains, oftentimes we have deficits in our sensory processing. Our well-regulated and appropriately functioning sensory system, so these are for typical people who don't really have any sensory issues. It helps contribute to proper social emotional functioning, our communication, our behaviors, our cognitive functioning, and our ability basically to do every single thing every day in our lives. A little bit of history. Okay, so in the 1970s, Dr. Anna Jean Ayres first described sensory integration as the organization of the senses for use. So Dr. Ayres was kind of like the godmother of sensory. She really started deep diving into all the research about children with sensory issues that she found. She was an occupational therapist working with children in California, children with disabilities. And she focused a lot of her research on 3 specific sensory senses, which is touch, proprioception, and vestibular input. And I will go into that more later on. Her research indicated that poor sensory integration often leads to challenges with postural control, bilateral integration, which is basically using both sides of your body at the same time to do different things. It is also her research indicated poor sensory integration often leads to challenges also with sensory sensitivity, discrimination, so the ability to understand the differences between senses, and or dyspraxia, which is also known as developmental coordination disorder. And I will explain dyspraxia more later as well, because that is also a term I know we throw around a lot. So what are some neurological concerns for sensory processing and sensory disorders? So neurological concerns would be optimal brain function is based on sensory input. A lack of sensory input during different stages of development can severely interrupt and cause learning or behavioral disorders. So think about the children who are, in other countries and they're rarely touched when they're born, or they don't get that good sensory input. Somebody who, gets born prematurely and then has to remain inside one of the NICUs. A lot of the time sensory processing disorders is just from early birth or even before birth. Things aren't getting input into our systems correctly, and therefore, as we grow and we develop more and more, it continues to have issues. Those with typically developing central nervous systems can adequately perceive and direct incoming sensory input without issue. And those with sensory disorders have a much more difficult time creating an adaptive response to sensory input. And so I'm not talking about, because we all have our sensory quirks, right? And for instance, I have a strong sensitivity to sound. And I know if I'm doing my work at my computer and somebody comes in like munching on their lunch, it's really going to distract me. Or if I can hear someone talking in the other room, it's going to drive me crazy if I'm trying to focus on something. But I can still go about my day. I've learned adaptive responses to these things. At nighttime, I actually wear earplugs because my husband breathes really loud and it really affects me. But these are for people who have all these sensory issues and just can't develop adaptations or modifications to their lives. And that's where we come in to help. So one of my professors put this on her PowerPoints a long time ago, and I always really liked it. And basically it's a funny paper, and the title reads, "Nancy's son Ben is in preschool." And so it's these two women sitting down for lunch, and Nancy says, so Ben has these sensory issues, clothes bother him. And then her friend goes, right, little guy likes to get naked. And then Nancy goes, yeah, it usually happens when he's anxious. Today I got a call from his teacher. And the friend goes, and Nancy goes, 2 words, fire drill. And then Nancy's friend goes, oi. So for those of us who are still a little sleepy, this is like OT humor 101. But last night when I was giving this presentation to my sister, she was like, I don't get it. So basically, Nancy's son has a sensory issue where he gets really anxious. He gets naked, clothes really annoy him when he's anxious. And there was a fire drill, which can be very anxiety producing. So a little funny before the intense stuff. Okay, so sensory systems. I know we've all learned the typical 5, probably since preschool, we've been learning these, right? And that's sight, hearing, taste, smell, touch. But there are 3 that I'm sure you've heard about, you've heard us talk about, but it needs a little bit more explanation, right? So 3 that I'm really going into detail are going to be tactile, proprioception, and the vestibular system, which are later on in the next couple slides. But quickly on this slide, I want to discuss interoception, because interoception we help a lot in therapy sessions. Interoception, basically this term means understanding the way that we feel internally. So what our body is doing inside of us, and we're understanding what it's doing. So this could be something like, oh, I really have to use the bathroom. I'm uncomfortable. I'm going to get up and go to the bathroom. Or, oh, my heart's beating really, really fast. I'm feeling a little anxious right now. All right, I'll go for a run and I'll try to mellow out. Or, oh, I'm really hungry and I just can't seem to focus on anything until I get a snack. So a lot of our friends, and oftentimes our friends with autism, have a really hard time interpreting what their internal systems are telling them, and it comes off as a behavior. So they're slapping someone, they're screaming at the top of their lungs, and you're trying to figure out what's going on. And they're hungry and they can't explain it to you, and they don't understand why they're feeling so uncomfortable, or they really have to use the bathroom and they just can't express or communicate it to the person next to them. Hey, I need to get up and go use the bathroom. So my friends later, my behavior friends and my communication friends, I'm sure we'll talk more about our autism kiddos and maybe more about interoception and how to help them communicate these feelings. Okay, so for the 3 that I'm going into more deeply, the sensory triad. OTs have coined this, the sensory triad. I think that it was my professor, Dr. Quinn, who actually coined this term, the sensory triad. And that is the vestibular input, proprioception, and tactile input. Those are the 3 systems that we are often helping and working with in occupational therapy interventions. Sometimes we use 2 at a time, sometimes we use 1 of those things, but oftentimes it's all 3 together. And these 3 sensory systems directly impact arousal, attention, affect, and action. And my sister also told me that I should explain arousal, because we think of arousal in one type of way, but for therapeutic arousal, heightened arousal would be quickened heartbeat, breathing quickly, really attentive. Heightened arousal is a good thing sometimes. If we need to be with heightened arousal, we're playing a volleyball game, we got to dive for the ball, or we need to do really good on a test and we have really good attention. So heightened arousal would be awesome. But there's also decreased arousal, which would be a slowed heartbeat, really calm, focusing on your work, kind of like the state you would feel when you're meditating, or it's more of a calmer state. So arousal can go it's on a spectrum. It can be heightened, or it can be low, or it can be just right in the middle. And we often deliver these 3 forms of input in therapy sessions in order to appropriately impact the 4 A's stated above. So proprioceptive input. What is proprioceptive input? When our bodies move about, proprioceptors, which are cells located in our muscles and our joints, provide feedback to the brain in order to recognize where our bodies are in space. And this is also known as body awareness. Why do we use proprioceptive input during therapy sessions? Okay, so it's to impact those arousal levels, right? To either calm them down or increase them. It's to improve body awareness and coordination for gross and fine motor movements. Oftentimes, we refer to proprioceptive input as heavy work. And some examples, so here's a little visual for us visual learners. Heavy work is making our muscles do some heavier work so that they kind of understand where they are in space and where our bodies are in space. So like this kiddo over here who is on the therapy ball, and I know you've seen us using these therapy balls, and he not only has to support his weight on his hands, but he also has to understand where the rest of his body is, because that ball is going to shift him around and he's kind of figuring out how to coordinate himself. So this is a really good proprioceptive activity. Wheelbarrow walking, similar to this one, pushing something, pulling something heavy. You know, if you're a weightlifter, when you use some dumbbells or something, you have to know exactly where your limbs are, because as you lift, you can't just swing it off and, you know, hit the person next to you. You're really focused and you're really coordinated on getting them up at the same time, clenching those muscles. Proprioceptive input is also like squeezing and providing input to the whole body with something like a weighted blanket or a gravity blanket. We really like proprioceptive input to calm down kids. You know, when you do a heavy exercise and you're exhausted afterwards, you feel good, you feel relaxed, you feel calm. So this is normally more for decreasing arousal levels. All right, so vestibular input. What exactly is vestibular input? The vestibular system is housed in a part of the inner ear called the vestibule. Oftentimes when people are talking about vertigo, you know, this is the same type of system, you know, when they're dizzy. This system receives information when the head moves, and this system helps us understand how fast or how slow we're moving and where we are in space. So proprioception and vestibular input are close in conjunction. They work really well together, or they try to help each other out. Why do we use vestibular input during therapy sessions? So we use vestibular input in therapy sessions to improve our balance, our postural control, our spatial orientation, muscle tone, alertness, and our eye movements. So our brains have to constantly adjust our eye movements to match our head movements, right? So when our head moves to one side, our eyes have to follow. And if that's not all functioning and processing correctly, we're going to be really dizzy a lot of the time because our eyes aren't going to know where our body is in space. And some examples of this. So here are a lot of vestibular tools we use at the school. Something like a rocking chair so that they get that back and forth motion, a slide, spinning around and around, bouncing, swinging. And let me briefly say that too much sensory input is not necessarily a good thing. So if you have a child or a person who is always at this heightened arousal and you put them on a spinner and you spin them around 20 times, their arousal level was here and now it's going to be through the roof, through the ceiling. You're not getting anything good out of them at that point. They're not going to sit down and attend to anything you want them to do. So vestibular tools have to be used in just the right amount of doses. And this is also it can be used in calming, like think of a baby, when you rock a baby back and forth, and slow linear movements with vestibular input is decreasing your arousal. So doing something really nice and slow, a swing, a hammock, those are vestibular tools that can decrease arousal. But oftentimes jumping on a trampoline, sliding down a slide, spinning around over and over again, that's going to increase arousal. And our final one in the sensory triad is tactile input. So What is tactile input? We know this one. Our skin is receiving and sending out information to the brain about the 3 different kinds of touch that we're understanding through our bodies. So that would be pain, temperature, or vibration. And why do we use tactile input during therapy sessions? Again, this is the word of the day: for arousal, for body awareness, and for processing. So with tactile input, I'll show you for our visual learners, here we go. You see us using a lot of these type of tactile inputs during therapy sessions, right? And for certain kids, this is going to cause different types of feelings. Some people might be a little tactile defensive, meaning that, oh, they really dislike tactile information. When they touch it, oh, they don't want to touch it and they shy away from it. So we would be using tactile input to expose them to more information, you know, start getting them slowly but surely used to touching things, used to their body feeling different sensations. It also, for a lot of kids, is calming. And when they play with Play-Doh or they play with Theraputty, something like that, they get to push and pull it, and they get to use their muscles, also using proprioception, and that kind of decreases their arousal level. It calms them down. And something like shaving cream or using finger paint would excite some people. It might get them, you know, their arousal level might increase as they're playing with it and as they're doing stuff, right? So it's all very manipulated for the specific child that we're working with or the specific person that we're working with. This is something like a deep pressure massage, which would be calming down a child or a person and giving them some good deep pressure input to sit down, do their work, you know, really feel some proprioceptive input and some tactile input in their muscles and joints. Okay, so we're moving on to a whole nother part of this, because we talked about sensory integration, and now I will go into sensory processing disorder. And this can get a little confusing. So let me just first tell you about who started this, who first started this term, what it means, and then we'll go into it more specifically. So in 2006, Dr. Lucy Miller first used the term sensory processing disorder to describe sensory issues in her book, Sensational Kids, which I heard is an awesome book if you're interested in this subject. Dr. Miller had originally studied under Jean Ayres, which was, remember, the godmother of sensory integration, and then continued to do research in sensory integration with other colleagues. Her primary aim for sensory processing disorder was to have SPD, sensory processing disorder, identified as a standalone diagnosis by the American Psychology Association and their updated DSM-5. Unfortunately, it has yet to be recognized as that, but continues to be a diagnosis often tagged on to other diagnoses. So oftentimes sensory processing disorder, you will not see this as a standalone diagnosis for a typical functioning kid or a typical functioning person, but it will be tagged on to autism spectrum disorder or cerebral palsy, right? And so sensory processing disorder is this big umbrella, it's this big term, and inside this umbrella is 3 smaller subtypes or categories, right? So the first one would be sensory modulation disorder. Then the next one would be sensory-based motor disorders. And the third one would be sensory discrimination disorder. A lot of disorders, but the next slides, you'll understand those a little bit more. So under the first subtype would be sensory over responsive. So just like I was talking about my hyper responsivity to noises, think about that, jog your memory. So the brain is not processing information appropriately and alters or magnifies the experience. Some examples of this. So this would be a child in the hallway with a lot of other children around them. The other children are kind of brushing into them, screaming, yelling, and this kid is freaking out because they just can't stand all this extra sensory input that's coming into their systems. And, you know, they just can't organize themselves enough to calm down and, you know, tell themselves, okay, it's going to be over soon. They didn't mean to touch me. They didn't mean to, you know, yell in my ear. Or this would be someone who there's an airplane flying overhead and that person just can't stop thinking and looking at the airplane, and it really disrupts them, how they're feeling. The air conditioning turns on in your room and they keep looking at it and just covering their ears. Nothing about that, nothing they can do can get them away from thinking about that air conditioning being so loud. This is also referred to as sensory sensitivity or sensory avoiding. So this person is trying at all costs to get away from that sensory input most of the time. Our next one would be sensory under-responsive. And again, the brain has difficulty processing and registering information. So this would be a child who's late to class because they didn't even hear the bell ring because they didn't even process that noise. They didn't hear it. It was off in the distance for them. They were focused on something else. They didn't even receive that information. This would be someone who has difficulty discriminating or registering pain. So I've heard stories about a child knocking their tooth out and the parent not even, you know, realizing until later on when they brushed their teeth because the kid didn't feel it. They didn't have that pain registering in their brain. It's also referred to as low registration. So in occupational therapy, we like to use this analogy where it's a cup, and your perfect cup would be not spilling over, not too low. Think of like the perfect cup of water, glass of wine, and that thing is perfectly centered. And you can walk around with it and nothing happens, right? It doesn't spill over. You've got enough. You don't have to go fill up more. Our kiddos with sensory modulation disorders, sometimes, like with this one, with a sense, oh, excuse me. Oh no. Oh, 1 second, guys. I messed up my mojo. Give me a second. Okay, here we go. Woo! Zoom, am I right? Okay. Alrighty, here we go. So with this one, their cup is overflowing. Their cup is filled up to the brim. They've got too much sensory coming in. They just can't seem to get it out of their cup. Their cup is overflowing, and it's hard to regulate themselves. For these guys, their cup is really low, and they just can't get enough sensory information to get it up to the right normal height where they can process and function in a normal environment. So we try and fill up their cup or take away from their cup as we deem fit so that they can be at their best functioning and processing for their daily lives. I hope that made sense. That was a little convoluted. All right. Our last sensory modulation disorder, our last subtype would be sensory seeking or craving. For the child's brain to register information, the stimuli must be much stronger than others. So examples of this would be a person who seeks out excessive touch or requires stronger hugs than others. This might look like someone who's constantly fidgeting or has impulsive movements. This kiddo really seeks out or makes loud, disturbing noises. These would be our kids that take our hands and, you know, put them on their bodies so that we can touch them and like give them this extra input if they can't tell us that they need it. Imagine the feeling of hunger and how if you are starving, there is nothing in the world that's going to make you not think about how hungry you are, right? It's like, and until it's satiated and until you're full, then you feel good. So these kids feel that feeling, but with sensory input all the time. They just can't get enough. They can't satiate their sensory information. They need it, they want it, and it's so hard for them to get it all at the same time as much as they need. So that's why it looks like they're screaming, they're yelling, they're shouting, they're doing things that seem behavioral, but really in reality, they just need that extra sensory input. So that's where we come in and we try and figure out, okay, what do you need? Do you need a weighted vest? Do you need to jump on the trampoline? Do you need to do some wheelbarrow walks? Yeah, I can think of quite a number of kiddos that we have who are in this category. And it's great because you can figure it out as long as you're willing to be patient and calm and work with them. Sensory things can be figured out. Okay, so sensory-based motor disorders. Those with sensory-based motor disorders have difficulty with movement due to an inaccurate motor planning and sensory processing. So dyspraxia, we talk about dyspraxia. If you remember earlier in the PowerPoint, it's also the developmental uncoordination disorder. This is the inability to plan and execute movements. So this could be with all different parts. This could be with their fine motor, which would make it hard for them to learn how to form pre-writing skills or to do their handwriting when they finally are done with pre-writing skills, moving on to handwriting. It would make them hard to figure out where their fingers are and how to touch each finger to each other. They just can't, they can't motor plan correctly to like grasp things and have a really nice coordinated grasping skills. For gross motor, it would be difficulty figuring out how to sit in a chair. I know we've seen someone or a kid who tries to get in their chair from the backwards, or they get in their chair like it's a saddle because they just can't figure out, okay, I pull out my chair and I sit my bum in, and it's just kind of 2 steps. But for them, they're like, oh gosh, this chair looks so confusing. How do I get into it? And then on the oral motor side, it would be difficulty motor planning to chew or to swallow, which are speeches they get into and they help our kids out with. For postural disorders, so those are people who have difficulty stabilizing their own bodies in response to environmental demand. Think about how you feel when you're riding a train and it's this constant movement, you're moving and you have to kind of be engaged. You have to engage your core. You don't have to think about it necessarily, but if the train abruptly stops, you're gonna have to catch yourself and know, all right, okay, my body's right here in the middle of space and I know where my body is. So these kids cannot figure out and cannot get their bodies centered in space. It's really hard for them to do any activity because their posture, they just can't get their posture right because they have low tone, they're not strong enough, to keep their body centered. So think about putting on your socks, how difficult it would be to get your foot up when you can't even sit straight, or putting on your pants. Basically every single occupation or activity is going to be difficult with either of these motor disorders. And for our final one under the umbrella of sensory processing disorders are sensory discrimination disorder. So those who are able to recognize a sensory stimuli, but unable to understand what that stimulus is or what's the intensity of it. This could be somebody who tastes something salty, but can't really figure out if it's sweet or salty. If they're feeling an object, they don't know the difference between a quarter and a dime. Whereas if we weren't looking and we're shifting through our purse, we can feel, okay, yeah, that's a little bit smaller. That's probably the dime or a penny. They understand that there's a distinct smell, but they don't really label it correctly. Basically, for these guys, it's just a stimulus coming in, but they can't organize it enough to know what it is. And we work a lot with this in therapy sessions as well. So who often has sensory processing disorders? Those with autism, cerebral palsy, and other developmental disabilities. And it's also associated with premature birth, learning disorders, traumatic brain injuries, and other conditions. It doesn't necessarily have to be any of these. It can just be what's seeming to be typically functioning person can have a sensory processing disorder as well. The exact cause is unknown, but research suggests irregular brain dysfunction. So like everything we've been talking about, right? It's a brain thing. So in general, just some sensory red flags that you can look out for with anyone around you. It could be kids, it could be coworkers. These are kind of some things that'll be like, oh, that might be a sensory. So fidgeting or often appearing overexcited, even during moments where there's nothing exciting going on, constantly trying to engage and oftentimes in inappropriate ways. A dull affect, so they might miss cues, kind of like that open mouth, like not a lot registering there. Someone who bites themselves or bites others or bites objects. You put their toothbrush in their mouth and they're just biting on it. They don't even want to brush their teeth with it. Someone who cries or avoids swings or slides. Or anything really, any equipment on a playground. If somebody doesn't like those things, it could mean that they have like an adverse reaction to vestibular input, to proprioceptive input. Somebody who jumps excessively, stomps their feet, slams doors or cabinets, even after you've shown them multiple times, this is how you softly close something. Someone who runs into walls, crashes on the floor, is seemingly clumsy. This is a person who has bruises like all over their body and they just can't seem to understand why, right? Because we all have that clumsy friend who maybe when we were growing up, you're like, oh, but who knows, maybe they had a motor disorder, maybe they had a sensory processing disorder and they were never diagnosed and they just kind of learned how to be that clumsy person. Sensitivity to light or sound, and someone who becomes upset with too many sounds or sights. So these are just a general understanding of some red flags, but always feel free to contact me or any occupational therapist and have them assess for sensory problems. And leading into how do we assess sensory integration issues or sensory processing disorders? So oftentimes it's by skilled clinical observation, administration of caregiver questionnaires. Some parents may have had a sensory profile that they had to do on their child. And also the use of standardized tests such as sensory integration and praxis tests, also known as the SIPT. And this is one of the standardized sensory tests, and it takes approximately 2 hours to administer. So it's a very long test, but it measures tactile input, vestibular input, proprioceptive processing, visual motor, and a ton of other sensory processing things. So that's a really good one to use as well. So how do OTs help with sensory issues throughout the lifespan? Because we can help with anybody from infants to adults of all ages. So for infants and toddlers, OTs discover motor and sensory difficulties and help with self-regulation. So wake sleep cycles, how to self-soothe, their alertness levels, their motor development and adaptive behavior. For school-age children, we direct interventions, modifications to the home or school environment. For adolescents and young adults, sensory integration issues can impede age-appropriate life activities. It can impede basically anything. It can impede their romantic relationships, learning to drive. Think about how hard it is if you have trouble putting your shoes on because you can't figure out where your body is in space. How are you supposed to hold onto a wheel, press the gas, press the brakes, do all the things you need to do in a car? It's going to make it really, really hard. Also making vocational decisions, figuring out colleges, how to navigate through colleges, and the list continues. So we use interventions to address these issues and provide accommodations to facilitate improvements. And moving on to adults, a lot of adults with sensory issues have never been diagnosed and therefore have had limited resources to develop coping skills or adaptive performance mechanisms. So we might have a 60-year-old that we know who has a sensory processing issue, and they've just learned to deal with it, even though it's really, really hard, because they didn't know that there was even a term for it, right? Many of these individuals have had difficulties doing all the things that I've mentioned above. And we can provide direct services and offer supports to improve everyday daily life with them. And finally, we are here for you. Occupational therapists are available in schools, private clinics, hospitals, and through physician referrals. We use client-centered practice to create intervention plans, cater to the individual and their family members to promote performance and maximize participation in daily living. So we are everywhere. OTs and also physical therapists do a lot of sensory integration help too. And please feel free to reach out with any questions. This is my email at the bottom of this PowerPoint. I know that this was a lot of information packed into a really short time period, and sensory, I can go on and on and on for days. So if you have any more questions, feel free to ask through my email.
Emery.
Yes.
This is Dorian. We have a question from behind the scenes for you.
Great, Dorian.
If Gail doesn't mind, this is coming from Gail Moore. Would correct me if I'm right, I don't know how to say this properly. Would trypophobia or trypophobia be considered a sensory disorder?
No. So from my understanding, I'm gonna have to, that's a great question, because trypophobia, can you spell it for me, Dorian?
It says that it's like the word try, T-R-Y, P-O phobia. So like trypophobia be considered a sensory disorder?
Trypophobia. So that's a great.
Keep in mind, we can get back to folks with the actual answers.
Okay.
Don't worry about it. No pressure, but that's the only question we have at the moment that I see. If anybody else has any other questions, please note that you can activate the Q&A at the bottom and submit us a couple questions. We still have a few more minutes before our next presentation.
Yes, because I will have to get back to you about trypophobia, because I am currently unaware of if it is or if it's not, but I'm happy to learn something new and to get back to whoever had that question. Okay.
Gail, don't try to stop. Okay, we'll get back to somebody with a great answer. Don't worry about it, Gail Moore. Anyone else have any other questions for our speaker, Emery Marjenoff?
And if not, if you're nervous or if you just want to ask later, I am available.
Right, you can submit all afternoon. Just indicate which session you would want to direct your question toward. That would help us because it's an ongoing stream of questions. I'm going to click the answer live so people will notice that we answered this question live, but we're keeping a track of all these questions so that we can get printed and posted answers to you by next Wednesday on our website, storckcenter.org/hot topic seminar. Mary Harris has a question.
Okay,
How
Mary.
do we find, here's a couple more. How do we find an OT for an adult in our area?
So you can talk to your physician, you can talk to your general practitioner that you go to, and you can kind of mention what you're feeling or what sensory issues you think you're having, and then they can refer you out to an occupational therapist. You can also look for, private clinics with occupational therapists, and you can also call our office because we're here too. Does that answer that question?
Our attendees are muted. Don't forget, they can't speak to us. So she
said, okay, so that's my final answer to that question.
And Mary Harris says yes. So that's good news. Let's keep on rolling. That's
okay.
Wonderful. Any more questions before we close out this session and get prepared for the next presenter? Yeah, we have one more coming in.
All righty.
Kanesa, would an oral motor disorder associated with swallowing necessarily happen constantly every time they eat, or can it happen sporadically?
So that would be more coined towards our speech therapists because they are more in our swallowing realm. That's kind of outside of my scope. So I will check in with one of our speech therapists and keep this question as well. And then I can get back to you and have one of them answer that and give me some nitty-gritty details on that one. Okay, because I'm currently unsure if it would be every time or just sporadically.
Well, fortunately, Jennifer follows you right after.
No pressure, Jen.
Maybe reserve that question for Jennifer when she comes on board. So Stephanie, stay tuned. If we can't get your question answered, we'll make sure that we get an answer back to everyone.